Hello, everybody. Happy Monday.
How's everyone doing? Glad to be back. Excited to be here. Want to talk about some more stuff with you today.
Yeah.
So introduce yourself.
Yeah, I'm Dr. Jake Anderson from Essential Motion Spine and Sport. I'm a chiropractor here.
All right, for those of us who don't know, us or myself, my name is Chris. I'm a physical therapist, EHS physical therapy, chiropractic. So, we combine out here and we have very specific, skill set on what we do, who we help, and, what we're trying to accomplish in our community. Let's just go ahead and talk a little bit about first, again, just introduce ourselves to even more of the people who have not maybe been, introduced to us or in our world, in our, sphere of influence yet.
Right.
What kind of things do we do here? Who do we help? What would you, if someone's watching and say, well, I don't even know if I trust those guys, like, where would I go? Like, here's what we do, here's what we believe in.
Yeah. So we believe in the combination of care. So we combine chiropractic, we combine physical therapy, and we have massage therapy too. We're the only clinic in the area that does it that way. And we believe we get faster and longer lasting results.
Yeah, I mean, there's a reason for that. There's a reason why we do it this way.
Yeah. So on the chiropractic side, we're good on mobility and getting the joints moving and everything. On the PT side, you guys are good at home stuff and giving them a plan to have not only increase joint mobility, to keep that mobility and then reduce pain in the long term.
Some strengthening, some exercises, some fitness, some things that you need to do, you want to do to get back to, but just don't have a good plan on how to do it. There's a little bit of fear, there's a little bit of confusion. What should I be doing? What should I not be doing? We essentially, we help active adults who have spine, joint, muscle pain. Return to fitness, return to strength, return to trusting their body, right? Having confidence in their movements through the use of chiropractic, physical therapy,
conservative measures.
Massage therapy. Yeah. I mean, we're trying to keep you out of the doctor's office. We're trying to avoid unnecessary surgeries, injections, being on narcotics for long periods of time, pain pills, all that kind of stuff. We're trying to help you avoid those things, the things that you don't want to be on. You know that there's another way to do this rather than just going to the doctor's office and saying, oh yeah, you need a fusion surgery, you need a total knee. Like, well, there's got to be something else I can try before that. I mean, that's the only option. Well, we're here to help you try to find those other options. But we want to talk about the hip today. The part for us that's always the most tricky or the most fine-tuned is differentiating between a true hip problem and a back problem. Yeah. That's just referring pain to the hip. It's actually quite common. I know it doesn't seem that way, but it's quite common when you have pain to the outside out here. You say, yeah, my hip hurts, when usually that's actually a back thing. But let's just say that for the, obviously we would take some, we're going to take more time with you, right? You're not just going to get a 5-minute in and out, doctor's appointment and say, yeah, take an x-ray, you're 65, you have arthritis, you must need a total hip. That's just the only answer. No, that's not the only answer, okay? We'll take more time with that, ask more questions, go in depth, and kind of differentiate between, first we have to understand where the problem is coming from, right?
So I think
where's it coming from, and then we'll help you with that.
I think that's one of the things that makes the combination of care unique here, and especially with the way we practice, is it's easy to go, oh, I've got hip on the outside of the pain.
Or say, oh yeah, I got trochanter IT band tightness. Well, that just because it hurts out there doesn't mean you have that. That's a very small percentage of people have that.
Oh, you're hurt here, I'm going to dive right in there, start targeting the hip. When in reality, we know that the spine, especially, can refer to many different places. So the location of your pain does not mean that is the location of the cause. The pain can be coming from somewhere else. Mm-hmm. And I think that's where, when we do an in-depth exam, I think we can find a lot of the times that you don't have a true hip complaint. It's a back thing. But for the purposes of our discussion today, we're talking a true hip. The back has been ruled out, a true hip issue. And we're talking about FAI.
We've moved you around now. We've tested.
Yeah, we've tested.
Loads, end ranges, different, we've moved this thing around all kinds of different places and say, this is actually coming from like the ball and socket, hip joint. Yep. So kind of explain what that looks like and what someone would feel like if they have that, which is
FAI or hip impingement, it's commonly known as. Yeah, so the hip we know is a ball and a socket, okay? So that's what allows us so many degrees of movement around that hip joint. But what can happen is you can have some bony overgrowth. So there can be more growth here. So when you roll that hip up and bring it into flexion.
Typically deep flexion, deep squatting. Or internal rotation. We'll get to that though,
Yeah, that bone will rub, cause a pinch, and produce a little bit of pain. You can also have it where the socket is actually like overgrown a little bit, and then there you're getting that pinch too. Regardless, doesn't really matter. Most of the time they say it's a combination of both that's causing that. but it causes that pinch pain, like Chris said, on deep flexion activities or internal rotation of the hip.
And typically deep in the groin.
Yeah, you can have groin pain
It'll be a different feeling, here as opposed to here usually. So usually when people say I have a hip, a hip hurts, well, does your buttock or like outside hip, or does like your deep in your groin hurt? And that's not always, but more of an indicator of like, yeah, it's a real like a hip thing. When you squat real low, sit real low, and it's just like it's really deep inside there. It'll pinch, it'll catch.
Yep.
Sharp pain. Usually, it's almost always intermittent. It's not always there. You can find positions or comfortable, positions where it's calmed down. Could even maybe feel a click or a catch.
Could have a click or catch,
in that inside of the hip. So there's a labrum around the outside of that hip joint. It's a little bit different. I mean, if you didn't see it, go back and look. There's a shoulder one that Jake did real well with how the shoulder sits on top of on the shoulder blade, right? So the shoulder blade is the part of that joint, and it's more like a golf ball and a golf tee. It's barely on there. Very minimal articulation, meaning like
joining.
Yeah, congruency, like where it's touching, but which allows for tremendous mobility, right? Hip's different. We walk on our legs. We have more stability, so a much deeper socket. It's more in there with decreased or less mobility.
Motion,
yeah.
Yeah, so
go through the two different kinds and then kind of what we would look for with that.
Yeah, so for the majority of people, this probably won't be a big deal, but if you're an athlete or you're involved in some sort of activity that requires you to like really get deep in like a squatting position or something like that.
Yep. So often, we see a lot of volleyball players here, right? So talking to the girls that have to be down. They got to be down low like this to receive, passing. Yep. This is a lot of hip flexion, so that can be like, ooh, it really pinches me in there.
Softball catchers, weightlifters, especially if you like squatting or anything like that.
Deep squats, front squats, back squats, overhead
squats.
squats.
And then I've even seen it in runners.
Okay.
So, yeah, the biggest thing is any activity where you're coming in like this or like this, you're getting that pinch. So what we want to do.
Maybe even swimming.
Yeah, you can see it swimming.
Because like that kind of whip type kick to the side there could really get you some pain in the hip.
Yeah. So from our standpoint, what we want to do is try to find a way to maximize the mobility or create more mobility in the hip, so you're not getting that pinch, or change the mechanics of how the joints, not only in the low back but in the hip too, are functioning. So you can buy a little bit more range of motion, so you can get deeper into those positions. Mm-hmm. So should we just go ahead and demonstrate?
Yeah, I mean, what we can't do, and it's okay. I mean, we can't change the shape or structure of your hip, bone or joint. But yeah, sometimes just because it looks that way doesn't mean that there's not something that we can still work on. And do you really care what it looks like on a picture if you regained your function and decreased? Like if you can do all the things you want to do, so what if it's got a little bit of a ridge, on an X-ray? Yeah. But what we'll often see though is they're going to go right in right away and do a surgery and do all these things, and because now they have a surgery for that. There used to not be a surgery for that, and lo and behold, that wasn't diagnosed very often because there was no surgery to. And now that they have a way to monetize off of that. Now everybody's got hip impingement. Any kind of hip pain's automatically like, oh, you need to go get that scoped and get that thing taken care of. It's not like all of a sudden people just got more hip impingements. It was always there, but there was never a surgery for it, so then they didn't do it. But now that there is, everybody's got it. But yeah, let's go through some things that we'd want to work on and see if we could calm that down, get some more motion, get some more function, and allow people to go back to get some strengthening. So they feel like they have some confidence in their bodies, and then they can get back to doing things. Yeah. Where would you want to start with that? Here, I'll hold here.
I'll show you one of the ones I like to check. And let's move over to the table here.
Yep. I'll grab this. What do we need? Okay.
So one of the things I like to test, here, I'll take the mic here, is how the position of your low back can influence the position of your hips and the movement you have available there. So normally we stand with a slight anterior tilt. I don't know if you can see that here. So my hips are actually angled down a little bit, which brings the hip socket itself back. So right here, I'm getting pinched more, and I can't bring my leg up as high. But if I kind of tuck my butt down, now I can bring my hip higher. So one of the ways you can change the way your body moves is just by loading the core. So my back is flat here. I'll hold the legs up. Yep. I call this a dead bug exercise. So you can just take one arm up overhead, slowly come up, all the way maintaining tension in the core and a flat back.
Yeah, he's kind of pushing that down there, rotating that back just slightly so it's flat.
And then you can slowly lower one leg at a time, tap the heel, come back up, again staying flat the whole time. This is going to engage the core, and when we go to retest some of those deep squatting positions, we should be able to get a little bit deeper and have less of a pinch. That was one of the ones I wanted to show.
Which other one do you want to
do?
Some hip extension or some
hip mobilization.
Okay, yep, go ahead.
Do you guys want to get in here?
It's just snack time for me.
Ah, snack time. Always got to be snack time.
If this is my irritated hip, I can get the band way up in the socket.
Yep, so we're just going to change the angle here a little bit higher. Just want to get the right pull on that guy. There, so he's kneeling in a half kneel.
So all I'm going to do here is let this band, I'm going to get that right up close in the groin here so I can get a little bit of pull on the hip. I'm going to drive my hip in and kind of lean forward with it and just let the band kind of distract or pull my hip a little bit in the socket. So what that's doing is just creating a little bit of gapping the joint space essentially. And again, you can drive that hip in, and you only have to do a handful of repetitions to notice a difference.
Now what if you put the affected leg down?
Yeah, so you could do the same thing.
Yeah, what if you went that way and kind of went to the side? Yeah.
Because you can still get a good gapping movement there. So you can play around, find out which one works best for you. Yeah, different angles, different movements. You can change the tension on the band. You find what works for you.
You even change maybe the a little bit of internal rotation, a little bit of external rotation, change the different angles.
So you can change.
Internal. That's going to be harder when your foot goes out to the side. I know that feels opposite, but when it goes out to the side, that's internal. And then when it goes that way, that's external rotation. Yeah, kind of weird.
All we're doing is increasing the mobility of the joint. So then, especially if you're a weightlifter, this is a good one to do right before you go and do squatting. You want to show us a strengthening one or two?
Yeah, we could probably get something on. Now, with single leg type things, we could probably do a little bit of, I like putting the affected leg down, to counteract, because when you have a weak hip abduction to the side here, when you lift the other leg up, if it's really weak, you're going to kind of this dip or this we'll call it a Trendelenburg or a weakness in that medius. So to go ahead and go both sides, it wouldn't be outside the realm to just go ahead and put like a little band around the heel. I know I'm going to move my right, but my left will actually be working harder to balance and not let myself dip down. I'm going to pull backwards and then back to straight. Backwards using the glutes this way, glutes here so I don't tip. Right, so we can go all the way around in a clock. We go backwards. We can go across. Now, if that really pinches you, just go to midline. We'll go this way. Turn, kick forward. Slow, controlled balance. And I'm gripping with my toes. I'm not letting my hip dip. And even though my right leg's moving, I'm feeling it a lot more in my left right now. And then off to the side this way. Here. I do the same thing on both sides. Remember we did the one with the squats with the band around the knees, pulling out. So what that looked like was like this. So we had here around the knees to kick the hip abductors in a little more, and then you don't have to we'll use a barbell. We don't have to use a barbell. You could use a kettlebell for a goblet squat or anything. And now I'm concentrating on, yep. So I'm concentrating on doing is not letting the knees fall in this way. I'm rotating them out with these muscles back here. I'm rotating out, and then I'm coming down into my squat, and then back up.
By forcing his legs out, he's inherently creating more space for that hip to move when he drops down in the squat.
My feet out a little bit so you can pan down. My feet are externally rotated just a little bit. I give myself more space. in through there. There we go.
So there's plenty of options available, plenty of solutions. You don't need surgery or anything for this, and you can get back to lifting, you can get back to squatting, you can get back to running.
That's just a couple varieties of what we would work on. There's more to it than that. I mean, there's some things that Jake can do with
Joint mobilizations,
mobilizations, manipulations, dry needling, some soft tissue mobilizations. There's other exercises, single leg stuff, double leg stuff, whatever you have available to you, whether it's barbells, bands, kettlebells, all kinds of stuff. So maybe it's just body weight. We can start with just body weight exercises and get you back to that function that you need to get back to.
Perfect. Thanks for watching.
Thanks.